Welcome to the Doctors Making a Difference podcast, where we help physicians to be empowered with the tools they need to be successful in medicine, in finance, and in life. Join us as we highlight doctors and other professionals around the world who are making a difference. I'm excited today to introduce someone to you here in a second. Dr. Sagar Naik is a really cool radiologist, and you'll hear it on the podcast, but think about this for just a minute. I'm a solitary fibrous tumor patient. I've actually never even met another person with my disease because it's so rare. And so I sat down by Sagar at a dinner at a financial conference I attended earlier this year, and we got to talking, and he said, "Oh yeah, I see patients with that all the time." He's an abdominal radiologist that reads at MD Anderson, and it was just such an impactful meeting to me to see a doctor who does a whole bunch of abdominal imaging on this specific thing that affects me and my family so deeply. He's a really inspiring physician, and I'm excited to share this with you. Today, I'm really excited to welcome Sagar Naik. So I want him to introduce himself, but I want to start with just a little bit of an introduction. Sagar and I happen to sit next to each other at a table at a white coat investor, financial investor education conference. And I just really enjoyed meeting him. I'm excited to share this conversation and to share some of the work that he's doing on the podcast. So Sagar, would you mind introducing yourself to our audience in more detail?
Sure. So I'm Sagar Naik. I'm a radiologist by training. I did a fellowship initially in interventional radiology and subsequently did an abdominal imaging fellowship. I'm currently at MD Anderson, work there as an abdominal imaging oncologist, oncologic radiologist. I live in the Houston, Texas area. I have a wife, 2 kids, and that's where I'm at right now.
You say it so humbly, but that's actually a really amazing resume, because I know you've done a lot of work and you've spent time in academia and as an interventional radiologist, and you've done an abdominal imaging fellowship, and now you read for a really respected institution and do a lot of stuff. I want to kind of give the audience a little bit of just the reason I was impacted by this is Sagar and I were sitting at a table, and the podcast listeners know that I am a patient of solitary fibrous tumor. I have that rare type of sarcoma. And so we were talking about different things, just kind of introducing ourselves to each other. And I mentioned he mentioned he was a radiologist. And I said, "Oh, have you ever heard of solitary fibrous tumor?" He's, "Of course, I read those every day." And I'm like, "What? It's such a rare type of tumor. Most people, when you say solitary fibrous tumor, they've never heard of it." And Sagar is a leading expert in imaging on abdominal sarcomas. And I was like, what in the world? What are the chances that I could meet someone that has such a deep knowledge on this particular topic? And I'm so thankful for someone with your expertise and wisdom. So how did you get interested in radiology in the first place?
I think it's been so long, sometimes you forget, but when I was in medical school, I really was drawn to a lot of areas, but I started really, I did a radiology rotation just as a lark, and I just kind of loved it. I was really drawn to the technology aspect of it. I think one of the first times I'd seen a CT scan I remember it was a patient that had some sort of teratoma, and it was just absolutely mind-blowing and could actually produce those kinds of images and see all those things. And so I was just drawn to it. And I like the personalities of the people that are actually working in radiology. It seemed like a fun environment. And I sometimes when you look at a case and you don't have a lot of information and just sitting there and thinking and kind of figuring stuff out, I really just enjoy that process. I just started enjoying it. It wasn't something that I was anticipating going into medical school. I'd never even really spent much time thinking about it, but I just started enjoying it.
So back up even further, you shared with me that you grew up all over the place. You spent a bunch of your childhood in Africa, and then you moved to the US as a teenager. It's just a wild journey to end up in the role you're in. And I want to hear that, just to briefly give us a synopsis on that experience.
Yeah, sure. I'm of Indian origin. My grandfather moved from India to Southern Africa. Zambia was country in the 30s, and then he went back and forth. But I grew up there. So my father grew up there. The rest of his siblings were born and raised there, and I was born and raised there. It's this community that's been a legacy of the British colonial rule along that part of the continent. World was part of the British Empire back in the day. And so, I grew up there. It was a wonderful childhood. A lot of good community of people we had around, had a good high school education. But around sort of college age, around college time, I at that point, I wanted to leave. I just wanted to get a better college education and explore what was out there. I had some relatives on my mom's side. My relatives live in the Los Angeles area. So I had a kind of a base that I could come to. And yeah, I left from high school and I went to LA. Luckily, I enrolled in a junior college. I finished high school and enrolled in a junior college there and did well and transferred to UCLA and graduated from there. And then went on from there. I had in my head, I wanted to be a doctor. It wasn't something that I had thought of when I was a kid, but I was really inspired by my dad's youngest brother. He became a doctor. He was the first doctor in our family. Otherwise, the rest of us were accountants and business people. And I was really inspired by him, and that's what I wanted to do. And I was lucky a lot of things fell into my place. But yeah, it's been a journey. It's been all over the place. Coming to the US initially was very difficult for sure, just the kind of cultural differences and so on. But I think I managed pretty well and eventually got accepted to a few schools. And when I was looking at the school, I really fell in love with Baylor Med School here in Houston, Texas. There was just something about the school I just loved. And so I decided to come here and then just ended up staying here for most of my career.
It's inspiring. And like I say, some of the podcast audience are medical students or residents or people that are thinking about this. And sometimes people, especially folks who say, look, I grew up in a place that's not your typical place where people who are in medical school grow up. And you grew up in this international, really culturally diverse, interesting place. But sometimes people would say, I feel like the cards are stacked against me. This is a pretty challenging thing to go to. But you went to multiple really well-respected academic institutions. And now you make this tremendous difference as a really experienced radiologist. So what would you say to 18-year-old you if you could go back in time and say, hey, this is a long journey, but what insights would you tell yourself it was worth it? Or what do you think?
Yeah, absolutely. I'd say it was worth it. I don't think I really understood what was involved. I think that was the thing. I think at least at that age, I had a belief I could do it. I think that was the biggest thing. I hear what you're saying. Sometimes you grow up in an environment where you just don't have any examples and you just don't think it's possible for you. But at least at that time, I did feel that, okay, this is what I want to do. And I just need to find a way to try to do it. And I probably did not look very far in advance, meaning I wasn't thinking 5 or 10 or 15 years down the road. I was simply thinking of what do I need to do for the next step, right? So what do I need to get to America? What do I need to do to get to college and so on? And so I think just that message of just focus on what you can and and then just keep working at that. Just keep working at that goal. I really did not fathom how my life and career has gone. I don't think I could have really planned it the way it has. Just the idea of essentially just trying to keep at it and having faith that it'll work as long as you try.
Yeah, I can relate. I think most doctors, when you talk to them, most people came from a background that wasn't like they had the silver spoon and they had everything given to them. I remember I spent a lot of time in my childhood. We had a small family farm in Idaho, and we had this little tractor with no cab. And my job was to go pick rocks all summer, go pick rocks and wear a bandana over my nose so I wouldn't get too much dust in my face. And that's what I did. And I had some doctors in my hometown and I looked up to them, but we never really went to the doctor much because you don't have any money. And you'd go there if you were really sick, but I really respected them. And I thought about that. I always liked science, but it seemed like such a far stretch to go from a farm kid on the tractor with no cab with all the dust. And that was my normal existence to say, I'm going to go to a big university somewhere and go to medical school and go on this big, long journey. But I would say that most people, when they set some small goals, it's really far to get to the end. But if you say, I can take the next step and I can take the next step, and that's essentially what you did. Just say, here's where I'm at and this is where I want to be. So let's go through the one step at a time. And in some ways, we all have that story as physicians, but in other ways, everybody has such a unique angle. And it's really pretty cool that you ended up in medicine with the level of specialty that you have.
Yeah, I want to highlight that as well, is that sometimes we think, at least I did, that our story is just ordinary, meaning that, hey, I'm growing up here and what do I have to say or contribute or there's nothing that I have that's different or unique and I think that's not true. I think no matter where you grow up or what circumstances you're in, even in growing up in a solidly middle class or we all have these stories. We all have these things that have happened to us and we all have unique perspectives and everything. And even if your life just seems amazing and perfect, you've had struggles. Everybody's had struggles and everybody brings a unique kind of thing to their practice and to the profession. So, trying to forget that also. We should also get that everybody has something unique to bring. And I think even for me, I'm not sure I knew that then, but it's been many years that I come to realize that for myself as well.
Sometimes I talk to my patients who feel like they're the only one who's going through something challenging, and they're going through like legitimately very challenging, difficult things. And I think what we've concluded is everybody's actually broken.
Yeah.
They might look like they have it all put together.
Yes.
But every single person you come across, they're living these challenging circumstances of mortality, and some got it easier, some got it harder. But if you look at it, almost everybody has challenges. So anyway, I want to commend you for what you've done, but switch with me for just a minute on specifically what you do. Sometimes I've talked to radiologists or other people who say, I went to medical school to help people, but I'm someone that's maybe, for example, let's say pathology or radiology, one that's doing a lot of support for other physicians and reading films or reading pathology specimens. And sometimes people will say, I'm not sure how big of an impact I'm having. It's just me in this room and I'm doing this thing. And I kind of reflect on that a little bit because I think you make a tremendous impact, especially as a solitary fibrous tumor patient. To me, what you do is incredible and impactful and amazing and important. But talk through that a little bit because throughout the course of your career, you've worked in different practice settings, and I'd like to hear your perspective.
Yeah. Yeah. That's certainly something that when you're talking about as a radiologist, you're just sitting in the back and you're just doing your things. And I think a lot of us radiologists, me included, feel that the work we're doing is not impactful, or that nobody really cares, or that it doesn't really matter. And a lot of that sense comes from we're not directly interfacing with the patients a lot of times. In my previous sort of job and career as an IR, I was doing that, but now I don't hardly. Actually, I do a little bit, but not as much. And also, one of the things over the years that has happened a lot is, whereas when I started my career, we would be in the hospital and we would be in the reading room, even if you're just a radiologist who's reading cases. You would be in the reading room where there's a lot of other radiologists. You'd be in the hospital. Clinicians would come down to the reading room to discuss cases because obviously they couldn't just access the PAC system, and the electronic system wasn't as widespread. And a lot of docs just didn't know how to look at the images. I think a lot of younger docs nowadays are very easily able to pull them up on their screens or whatever. So there was a lot more of that collaboration, and a lot of that was there. So as a radiologist, you did feel that. You did feel when a clinician came down to talk to you, or you got to know the docs really well. But what's happened since then is certainly COVID accelerated a lot of it, is that a lot of our reading is done very remotely. Sometimes we're at home. Even if we're in the hospital, a lot of it is remote. So sometimes the systems are so big that it's hard for clinicians to gather, or a doctor to come into my office and say, hey, Sagar, what do you think of this? This was read by... Not having that kind of personal interaction on a daily basis can make you feel like, okay, what am I doing here? But I would say that, and it's taken me a while to get here as well, is that I have had so many experiences now doing this day in, day out, where I've read a case and I've seen a follow-up to the same patient and read a note about how one thing I picked up made impact because maybe it had been missed before. It made an impact in the way the patient was treated differently. And then there's a lot of other, like for instance, you're talking about solitary fibrous tumor as an example. A lot of kind of routine way of understanding whether the tumor is getting bigger or smaller. Traditionally has always been based on size, right? Is it getting bigger? Is it getting smaller? Is it disappearing? Right. But a lot of these tumors, solitary fibrous tumor is one of them. A lot of others, the newer treatments that are the kind of the immunotherapy treatments, don't affect the tumors in exactly the same way. So on imaging, the tumor may look exactly the same size, but the morphology changes, the density measurements change, the borders change. And having a very deep and nuanced understanding of a lot of how the treatment and how the tumor behaves based on a month or 2 months or 3 months from now behaves on imaging. Having that understanding makes a huge impact on the treatment protocols, right? Because a lot of times, whatever you were saying as a radiologist is essentially telling the doctor and clinician whether the tumor is getting better or worse, whether therapy that you're doing is getting better or worse. And that's just for solitary fibrous tumor, but that's also for many different types of cancers as well. I work with a group of doctors who deal with appendiceal cancers, which are very rare actually. But understanding, for instance, that a low-grade appendiceal tumor behaves very differently from a high-grade appendiceal tumor, understanding the difference. So when I'm reading a CAT scan on a patient 2 years after the tumor was removed, and I see no metastases or anything like that, I should understand what the tumor is doing. Because if I don't see anything for a high-grade tumor, that means something's wrong. That means I've missed something. That means I haven't looked at the images carefully, or I haven't looked at the specific places that I know this tumor will go to, for instance, and it may go to the pelvis, which is often easy to miss. And so I know that I need to go back and take a look, just take a little bit extra time and look in that area just to make sure I haven't missed anything. And every time that happens, you're always accepting the treatment of the patient one way or the other. And so I think it will make a huge impact. And I think just being aware of it, just being mindful of it, that makes a huge difference. I think just as a radiologist, just to, make you understand that you're having an impact.
You have all this deep knowledge and expertise of reading it. And I think that's where the real big impact, because your career has spanned the time, like you say, where everybody had to come down to the reading room if they wanted to see the images, to where everybody could probably pull up those images on their workstation or maybe even on their iPad or whatever in front of them. But the value comes in having looked at it again and again and having the depth of knowledge of having read thousands and thousands of cases. You get that level of nuance and expertise. And so as a patient myself, my whole life hinges on what the radiology says. I've got another CT next month and I'm already thinking about it. You start getting scanxiety where you start saying like, what's going to happen, because that impacts treatment. It impacts prognosis. It impacts almost everything. And so not only is impactful to the physicians who are counting on those reads, but for those of us who are dealing with the disease, everything in your whole life depends on what does that scan say. And you don't want the radiologist to miss it, and you don't want them to overcall it or undercall it. But like you say, you're looking for subtle details, not just putting the ruler on there and measuring the size. You're looking at depth and density and morphology, which is really actually very detailed and nuanced and complex. So anyway, thank you for what you do. It's amazing.
Thank you. Yeah, appreciate it.
One other question. Oh, go ahead. Go ahead.
I was just going to say, it was funny when we first met. I remember we were laughing, we were joking that we're exactly on the opposite spectrum of medicine.
Yeah.
Where you have this really broad array of things that you're doing on a daily basis. And I am like extremely zoned in or honed in, subspecialized. So that was just funny.
No, it's true. I work in a rural area in a small town. You have no idea what's coming through the door. We see every age and every condition. And a lot of times in a small town, you can refer somebody somewhere else, but it's an hour and a half drive each direction to go to another specialist. So a lot of times I'm the one managing it primarily, or making a couple of phone calls, and then you get the ball rolling, and then, okay, I got to connect you with this person that knows more about this particular disease. But you do have to be a jack of all trades. And in your job, it's so specifically narrow. You only do abdominal imaging and at MD Anderson, which is going to be mostly cancer cases. And so it's like you say, very broad spectrum across this. If you're thinking about medical school, if you're a person listening, you have thousands of jobs at your disposal, and you can be a super duper subspecialist, or you can be a generalist that does a lot of stuff. It's just whatever. They need doctors everywhere.
Absolutely. Absolutely.
One question I was going to ask you is, over the course of your career, you have seen, no doubt, a tremendous change in technology, because like I've been in post-residency about 15 years, and even in that time, I've witnessed quite a few changes just on the quality of images and what's available. Even in our small little hospitals, almost everybody has MRI imaging capability and high resolution CT images. And we just now count on that to be immediately available. But even when I started medical school, most little hospitals were just getting their first CT scanners, and they were not nearly as good as the ones are today. And we relied on X-ray for a lot of things. And so I wanted to hear your comments on how your job has changed over the course of your career based on the imaging technology that has been available.
I think the short answer is the volume. The volume has changed dramatically, I would say, even over the course of my career. As a resident, I remember the surgery resident or the medicine resident at ER had to get approval from us just to order a CT scan. And sometimes we'd have this back and forth. As a resident, you do all kinds of silly things, I think sometimes. Not silly, but it was just a fun look at that. And that was because in that era, you ordered a CT scan. A CT scan took several minutes just to get done. Once it got done, you printed those images, and then they were stacked, and then the images had to be taken somewhere, and then they had to be and then the radiologist had to look. The whole process took forever. If you're a surgery resident and you want to order a CAT scan, even of a head CT, by the time somebody even looks at it, maybe an hour, a couple of hours, something like that. And if you want to look at it as a surgery resident, if you want to look at it, you have to come and go to the radiology room yourself, reading room yourself, and pull up And I remember starting there and now today where a scan will take seconds, for example, to be done. And seconds after it's done, within a minute, a couple of minutes, it's immediately available for almost all radiologists in the system to review it. So from the time the patient hits the scanner to the time there's a final report, it may take a little bit longer because there's some QA and all this, easily to be minutes, whereas it used to be hours before. So it's just made, and that by itself has just led itself to just a lot more volume. Because once again, the scans are easy to get done. And of course, they're a lot easier. Reports come out a lot faster as well. So just the process has made everything easier. And so the volume has shot up quite a bit. And I think that's the main thing. I think from a technological standpoint, there's a lot of improvements in the imaging technology, for instance, in ultrasound or MRI, all of those modalities in terms of the equipment itself. So yes, I would say that the imaging overall has gotten better over the years, meaning just the quality of the images. There's definitely certain things that I remember, even now when I read CAT scans, for example, now I see all these anatomic variations, vascular variations, and all these variations that I remember a resident learning that they were extremely rare, but I see them all the time now, not because it's a cancer hospital, just because we scan so many patients and there are all these variations that we just either didn't detect before or we couldn't know. But there's a lot of stuff like that I think has changed. But I think the main thing is that the volume has shifted significantly. And then, of course, going back to our early conversation about the actual practice of imaging, whereas before it really was a more, you had to go to the hospital. There were a lot of built-in stocks to a very inefficient process, right? And now literally anybody can read from anywhere. A lot of work, a lot of radiologists are fully remote, reading from home. So yeah, a lot of those changes. There's a lot of that has happened.
Yeah, and it does impact patient care, that speed of images in these. Yeah, and you go from a large institution down to the smallest of institutions like where I'm at. And I'm reflecting on a case a few weeks ago. We had a middle-aged, otherwise healthy woman just suddenly lose consciousness and came into the ER and all the life-saving things to try to help protect the airway. But the CT imaging was done right then. And we have a visiting radiologist and he happened to be in-house. And so I was in the reading room or in the scanner. We're watching the images come off one slice at a time and he's reading it and he's right there. Oh, it's an aneurysm. And then we activate the transport that she needed to go to get a coil placed. And the imaging stuff is what really helped her because she was able to find a diagnosis and she was able to go up to a place that could do a coil-based therapy and just really managed her case. And years ago, that would have been like, she's had lots of consciousness and her one pupil is slightly bigger than the other. So here's the broad differential and we'll observe her and see what happens. And it made it much more precise and very impactful to that individual and other patients who count on it. So you're right, it is a big increase in the number because it is so tremendously useful for clinical medicine. And I think it really impacts the outcomes of our patients in a way that it never could have I would say even 20 years ago.
Absolutely. And then the other thing to your point there is that you don't necessarily have to have a radiologist in the room for that patient, right? The radiologist could have been sitting here. It could have been me reviewing that while the patient's in your ERs. A lot of that, there's been a lot of that tremendous improvement as well.
Oh yeah, for sure. Most of our reads happen with a remote radiologist that is remote. That one was just unique because it was in the moment. He just happened to be there and he's like, come look at this. But most of the time we're transferring images and we're getting reports back within a pretty short time window. And it is actually quite efficient in most cases, but there are times where you get some delay because of that volume. So I want to shift for a second, just get your insights on, everybody wants to talk about AI right now. It's a big hot topic. Radiology, well, students that I've spoken with express concerns and say, will I still have a job if I become a radiologist? And in my mind, I'm like, of course, there's so much to do and there's so much nuance. And I don't think that having large language models try to replace a physician would work. And the cynical part of me says, who would they sue if they can't sue the AI company? Which is probably too cynical. But I am curious from your vantage point, to manage that tremendous volume of images, is there a place for AI in radiology? And where do you see that augmenting what you do? Because I don't think it's a replacement, but how do you see that tool coming to play over the next couple of decades?
Yeah, okay. So I'm not an AI expert by any stretch of the imagination. There's definitely people in our group who've worked with the AI models and as such a little bit more than I have, a lot more than I have. I can speak to what I see happening in just in our practice and what I see, what I think will happen, meaning from a kind of a lay radiologist standpoint. I think that for the near future, and not to even, when I say near future, I do need a couple of decades at least. What is going to change a lot, right, is our own efficiency. So, for instance, I'll give a very quick example. When I started my career, we would dictate, and when we would dictate, there was a person transcribing our reports. Okay. And when I started in those days, I would dictate so fast. I would mumble through words. I would say all these things. And the transcription was so amazing and they got to know us. And so it almost didn't matter like how quickly I said things. There were very few errors because they were able to fix all those things, transcribe it, and get it done. Okay. Eventually, we went to a voice dictation model. And the voice dictation model, which we've now had for 15, 20 years, it's gotten better, but it's still nowhere near a live transcriptionist transcribing your report because it makes a lot of errors. So a lot of times, for example, that's just one point I'm talking about, but a lot of times we're actually just spending a lot of our effort correcting the report, make sure there's no discrepancies. I may say in the body of my report, there's no cancer. My impression says no cancer or no metastases. Often it logs off the word no, and the first word is metastasis. Sometimes we don't catch it. So there's a lot of that stuff where AI will help us. In a lot of ways, for instance, just the reporting part, it's almost we're going full circle where a lot of AI models now can basically listen to what you're saying. You don't have to say everything in a very specific, precise manner. You don't have to try to say your words in a specific category because the AI will listen to it and automatically put everything where it's supposed to go in terms of the structured reporting template, and then check for mistakes. So if you said no and here says no, and here he says yes, it'll ask you. If you say right in your findings, by the impression you say less, it'll ask. So I think there's a lot of that kind of changes that are already happening that will just increase efficiency significantly more. That's just on. So I think that a lot of what's going to change is I think we will just get a lot more efficient. The radiologists will get a lot more efficient in producing the reports. Then there's also, there are certain programs that are now coming out where they're looking at very specific things. For example, we have one that really every time a CT scan opens up, the images get processed through this one application that only looks for pulmonary emboli. Okay, only looks for pulmonary emboli, and actually does a fairly good job of it. So, and that will flag you if it thinks there is a pulmonary embolism. So that's one example. But now, when I'm reading a scan of a chest, abdomen, pelvis, I'm not only looking for a pulmonary embolism. I'm looking at the thyroid gland. I'm looking at the lungs. I'm looking at the heart. I'm looking at the skin. I'm looking at the liver. So one has to have an AI model or an app that's going to essentially look for every little thing. To me, that seems, I'm sure it'll happen at some point. But to get there now, I would think that that's a long road to actually get to that particular place. And so, and even then, you still need a medical background. You still need an understanding of when you're looking at image, what it actually means in the context of a patient, in the context of a patient's treatments, and so on and so forth. Just because the AI picks up pulmonary embolism, that doesn't mean that that's significant, and so on. So I think I could be 100% wrong, but I don't foresee AI replacing a radiologist anytime soon. I think it will enhance what we do significantly. It will I think that in a lot of ways, it will make our work easier. In some ways, it may make it worse. I think we'll just be expected to potentially read more cases because we can read it faster. But yeah, that's where I think the direction is, at least for now.
Yeah, good answer. Thank you. It just seems to me like all AI or large language models, it just puts information, a lot of information immediately in your hands. You don't have to spend time researching stuff. So I think it can enhance, but I just don't ever see it replacing. Our jobs will look different in 20 years because of AI, but I don't think there's ever going to be a time like, okay, I don't go see the doctor. I go see my AI robot and it tells me what to do, because no matter how you shake it, large language models, that's all they are, is you're associating facts from published data and trying to get credible sources. And it is really a useful decision tool or a computer model that bases it on all these associations. But the human component of it has to be there. And so I think that we just have to adapt with it, not be fearful of it, but adapt and say, this is going to be part of the future, and look at it in a practical way and try to make use of those tools rather than be fearful.
Absolutely. And even like that PE model I'm talking about, we do rely on it. And I will always check it, make sure that as I'm reading the case, I do check it. And so I think so far, as far as I'm concerned, I think so far, I see a lot of positives. for our workflow. But I personally am not worried about being replaced by
No.
an AI.
So one more topic I want to hit with you, which is you and I have lived through this time where lots of doctors have left medicine. And it's a little bit disappointing or frustrating or sad because we lose these wonderful experts who get so frustrated and burned out by a system that doesn't always value the life and the well-being of the physician. And so people say, I've had enough. And you and I met at a financial conference. Like, it's really important to have your finances in order so you can be a good doctor. I would argue that you're a better physician if you're not doing it because you have your feet to the fire. And if you don't do this, you're not going to be able to make your mortgage payment or your student debt payment or whatever it may be. There's a tremendous benefit to kind of having your financial house in order. And then hopefully medicine becomes a joy rather than a burden. But I wanted to hear your insights or comments on that because I think it's pretty important that we keep physicians delivering medicine to the best of their ability.
Oh, absolutely. And I was there too. I went through some career transitions. As I said, I was doing an IR and then I made some changes and I was 100% there. I think at some point, even I was, like you said, we met at a financial conference and my goal a few years ago was just, okay, I need to just I need to get to this and then I'm out. And I was 100% there. And I remember having this conversation with a CEO of a company, a friend of a friend. I'd gone to their house and most of these people were not doctors and in Iraq were just having a conversation about some things. And he said something that was really interesting. He said, most people think that they don't like the work that they do. They don't, or they get tired of the work that they do. If you're an engineer, they get burnout, it's because they don't like engineering anymore. And what he said was like, that's not true. Most of the time, what happens, most of the time, it's not the work. It's just everything around the work, right? It's the people you're working with, the company you're working with, the circumstances or environment. So change your environment. I remember this very vividly, exactly where this person was telling me this. And it made a huge impact on me. And because I did get to a point where I was like, okay, I hate this. I hate radiology. I hate IR. I hate this. I don't want to do this anymore. And I really had to sit back and reflect. And out of long reflection, I began realizing that no, it wasn't that. And today I'm 100% certain that there's lots of parts of radiology that are boring and just like with anything else, right? There's lots of parts that are of the practice of it that's frustrating. But I think a lot of our burnout and frustration does come with all the stuff that's around, that's making just the practice of what we enjoy harder, right? Whether it's administrators or whether it's insurance companies or whether it's the hospital setup or whatever it is. I have my own things that I was just really frustrated with. And after reflecting on and making some changes, I realized what was going on. And even today, I'd love to go back to doing exactly what I was doing before with the same knowledge that I have now. So I want to continue practicing, but I think it's extremely important. Those of us in our 40s, 50s, 60s, we're at the peak of our knowledge, our expertise. And it's unfortunate that it's around this time that everybody starts getting burnt out. You have family pressures, you have aging parents. And so I think we're just at this point where even though our expertise and is at the top, or we're at the top of our game in that regard, we're having all these other pressures. And sometimes it's hard to separate, right? It's just hard to separate everything that is happening around you with your career and then that burnout happens and you feel like you need to get out. But 100%, I would agree that trying to get to that state of financial independence or trying to get to the place where you think that you don't need to keep doing this for the money is extremely important. And I'm still working towards that. Just leaving medicine entirely, I think it's a tremendous waste. And it's especially for those of us who have spent so much time doing this and we have such a breadth of knowledge and so much expertise that it's and one can tell with the impact of, especially what's happened since COVID. In our area now, getting a neurologist and, an appointment for a neurologist takes 6-7 weeks, if not more. And prior to that, it would have been maybe 2 or 3 weeks or 4 weeks. I remember even 5 or 10 years ago. No, I agree with them. I think the burnout is real, but I think it's really important to reflect and think about what is actually burning you out, right? Is it the medicine part? Is it the circumstances? Is it your environment? Is it maybe a family situation? What is it exactly that's creating this sensation of frustration and burnout? And then really reflect on what one can do to mitigate a lot of those, right? Rather than just saying, all right, I think it's done with this, throwing the baby out with the bathwater kind of thing. But yeah, I think that there's just so much expertise, so much knowledge. I think it's a tremendous waste to just lose it because of all these other factors that makes it just difficult.
Yeah. No, this is important because we kind of wrap up time, I think that's one of the messages that I want to leave with our audience and just reflect with you. If you don't like it, change it because you're still needed. And if you don't like the hours, change those. I mean, and one of the big arguments, like you say, is to kind of get yourself financially independent. It's not to leave medicine, but to try to find a way to live in that world and be able to adapt and change so that you can keep doing this meaningful work and find fulfillment and joy in it. But Sagar, I have really enjoyed this conversation. I really appreciate what you're doing. Like I say, what you do makes a tremendous impact for people like me. And
Thank you.
You're an inspiring guy. So I really appreciate you taking the time to share with our audience. Thank you so much.
Thank you, dear. Appreciate it. Really enjoyed the conversation. Honored as well. Thank you so much.
Yeah, thank you. Thanks for tuning into the Doctors Making a Difference podcast. And thank you for what you do to help your patients and your community. Your work truly helps so many people. We produce this content to help you have the tools you need to stay in medicine and to highlight the amazing work being done by physicians around the world. Please note that while I am a physician, and many of the guests on this program are also physicians or other professionals, the discussions on this podcast do not represent my employer or any professional organizations to which I belong. This podcast is for your information and entertainment only, and should not be taken as professional advice. You should seek appropriate professional advice pertaining to your own situation. Please check out more of our content on our website, doctorsmakingadifference.com. Also, please follow, like, or subscribe on your podcast player or YouTube channel, and give us a 5-star rating. It really helps to spread the message. Finally, if you'd like to be a guest on the podcast, or if you'd like to nominate someone else to be a guest, please visit the website or email admin@doctorsmakingadifference.com. See you next time.